So the next speaker is Dr. Parveen Sen. She is a consultant vitreoretinal surgeon at Agarwal's Eye Hospital, Chandigarh. It's a mystery for all of us in retinal dystrophies, especially the electrophysiology. Madam will make it very lucid for us.
So thank you, Shane, for the invite and the introduction. So I really hope I'm able to make it lucid for you. That is the aim. Yeah, so I'll be talking on electrophysiology and multimodal imaging put together for retinal dystrophies. So why should most of us have this? First question is, why should we be doing any investigation whatsoever for retinal dystrophies? Because there is no treatment. But it does help in making a diagnosis, helps in targeted genotyping, helps in making a prognosis and explaining it to the patient for better understanding of disease. And in few situations, you may actually identify the underlying gene defect, and I will take you through this step by step without overwhelming all of you. So the first and the most common symptom that you may come across with the patient of retinal dystrophy is night blindness. So this is the picture that you will have of a patient who complains night blindness. It may be an absolutely normal fundus, or it may be stippled pigmentation. So if you do an ERG, you have a normal fundus and a negative waveform, your diagnosis is going to be congenital stationary night blindness. If you have this kind of bony spicule pigmentation and your ERG is flat, then you can make a diagnosis of retinitis pigmentosa. If you have this tapetal reflex and a negative ERG on a combined response, you can make a diagnosis of Aguchi. Night blindness, white spots on the fundus, and a reduced response which becomes better on prolonged adaptation is going to be fundus albipunctatus. Second thing which you more commonly see is negative ERG. So without going too much into detail, negative ERG means you are getting a good A wave but not getting a good B wave. So here, if you have a foveal schisis with negative ERG, it is X-linked retinoschisis. If you have lots of hemorrhages and you do an ERG and you see a negative waveform, it is central retinal vein occlusion. If you see a foreign body and you see a negative wave, this could be a beginning of siderosis. Another common thing is lots of white dots on the retina. So if moment you see white dots, you should definitely ask for an ERG. If you see white dots and you see a normal ERG, it is benign fleck retina syndrome. If you see white dots and you see a reduced scotopic response, predominantly it is fundus albipunctatus, and if you see white dots and a flat ERG, it is retinitis punctata albicans. So this is how you image it and you do your ERGs, but sometimes you don't get an answer all the time on just a photograph. So you see white dots, but more or less the ERGs are looking similar. You do an FFA and you see that the fundus on the right has these well-defined areas of choriocapillaris loss, and on the left is plenty of flecks. So here the first case on the left is your Beatty's crystalline dystrophy, and on the right is fundus flavimaculatus. So the imaging and ERG put together actually gives you the diagnosis. Near normal looking fundus, some yellowish flecks at the macula, ERG is normal, multifocal ERG is down, and this is Stargardt's disease. Near normal looking fundus, and you see that your ERGs are normal, multifocal ERG is down, but you see how much are the flecks on FFA. So this is fundus flavimaculatus. Again, similar looking fundus, and you don't know what you're looking at, but ERG is almost extinguished. So here you're looking at a cone rod dystrophy. Similar, doesn't tell you the story, a near normal looking fundus, but you see you do a multimodal imaging along with electrophysiology and go back to your history, and the patient is having hydroxychloroquine toxicity. So no single test gives you all the answers, but if you combine it very usefully with your knowledge of electrophysiology, you can answer a lot of these mysteries. Taking you to this spectrum of BEST1 mutations, which is not often discussed. So you can have a well-defined macular lesion, and if you don't know what it is, you suspect it's a bilaterally symmetrical disease. You do an ERG, which is normal. Multifocal is slightly subnormal in the center, and you see EOG, which is markedly down. You know it is vitelliform disease. Here, this is also a BEST1 mutation, but you have a foveal schisis in the center on OCT, yellowish dots in the annular area around the arcades, and you have an ERG which is slightly subnormal, EOG which is markedly down. This is autosomal recessive bestourinopathy. This is bilaterally symmetrical. Patient is older, around 50s, may be referred to you as having AMD, and then you do your OCTs, you do your ERGs, and you know it is a non-progressive adult onset vitelliform disease. So this is how you do your OCT and your octal, looking for a CNVM, but there is none, because this is adult vitelliform disease and it is not AMD. Adveric is a rare form of disease where you can have a markedly reduced rod and cone responses even in the presence of BEST1 mutation. Just a couple of slides on congenital stationary night blindness. Near normal looking fundus you see here, and a typical normal OCT, and you have a typical beautiful negative waveform. Only A wave is present, no B wave. Photopic otherwise is normal. This is congenital stationary night blindness. You have this tapetal reflex, and you have a negative waveform. This is Aguchi disease. You cannot miss this one if you have an optos. So this is some beautiful phenotyping which leaves you with no doubt as to your diagnosis. So what about reaching which is the underlying gene? Can we do that? So in some inherited retinal disorders which are caused by a single gene, you can actually do it. As I showed you with XLRS, you know that the underlying gene defect is RS1, so you actually need not ask the patient to undergo any genetic testing. Another test which I found very useful in XLRS is this. If you see beautifully, this is the fundus autofluorescence compared with this fundus photograph. So if you see, I don't have a pointer here, but the area of schisis corresponds to the area of hypoautofluorescence. So if you cannot clinically pick up where is your split, you just have to do an FAF and that's it. You know it exactly where the split is. So this is how it helped me. So the young patient, and I saw marked loss of vision, but I didn't think that it was a split, but actually the split had happened, and already the area was totally atrophic, and this is the corresponding ERG. If you see the ERG on the left hand side, the amplitudes of the negative waveform are even lesser as compared to the right, so it is helping you prognosticate as well. So if your amplitudes are lesser, means the disease is worse. Another example, you can see the area of split very nicely on a fundus autofluorescence, and if you see on autofluorescence, there is some area, dark area at the macula also. So when I did the OCT, you could see that the macula was also involved in the split. And this is the other eye of the same patient, and I did not do anything for the patient because it was not retinal detachment which has caused the drop in vision, but that the split was involving the fovea, and on the left hand side there's a complete loss of ellipsoid, because again, though you don't see the split, but it has already happened there, and this is degeneration following the split. Another example, enhanced S-cone dystrophy, typical fundus features of an annular, either annular ring of pigmentation or annular yellow spots or annular subretinal fibrosis. This is typical of enhanced S-cone, and if you do the ERG, enhanced S-cone means there is a total loss of cones. There are three types of cones, L, M, and S. So in this disease, L and M cones are absent, S cones are present. S cones behave more like rods, so the photopic and scotopic ERGs look identical, and this can be caused only by the NR2E3 gene. So by doing a phenotyping, you know what is the genetic defect. Typical example, patient comes to you with cone dystrophy, a bullseye maculopathy, you get a ERG done thinking that you will see flat responses. Here, the photopics are flat, but look at what's happening to the rods. They are higher in amplitude. Flat cones, high rods is only because of the KSOS2022 gene. So ERG and phenotyping is telling you the genetic story. Another example of the same one, bullseye maculopathy, flat cones, very high rods, and this is KSOS2022. Retinitis pigmentosa, just one or two slides. It can be caused by more than 100 genes. We call this atypical. This is not atypical RP. This is typical RP, behaves like RP, symptoms of RP, extinguished responses. Only the clinical picture is like that of these widespread peripheral CRA marks, but this is because the circle mutation presents like this, and most common mutation causing RP in India is circle. So this is not atypical. Again, RDH12 may present like this and not with peripheral bony spicules, so this is still RP. ABCA4 may present like this with central involvement. This is not atypical, it is just that it is ABCA4 causing RP, and it may not be extinguished. That's because actually the peripheral retina, if you see, is still pink, which means some amounts of cells are still working, even though the vision is huge. So this is PRPF31, which gives you CME, and this is, the knowledge of this helped me diagnose this patient. Patient came to me with a history of recent drop in vision, 54-year-old, diagnosed to have macular hole, and came for macular hole surgery. But I saw these, on OCT itself, I saw these well-defined round lesions, and this made me think whether it was a milder form of RP. We got the genetic testing done. ERG was also slightly less, and the genetic testing showed us PRPF6 mutation, which is an autosomal dominant form of RP, which is a mild disease, which explains why the patient had presentation much later in life. So knowledge of ERG, you may not become an electrophysiologist by knowing it, but one more test will definitely help you in making many more diagnoses.
Thank you, Dr. Parveen. I have one question.
Yes.
We had a couple of RD surgeries, post-RD surgery. One was a buckle, other one was vitrectomy, oil removal. Patient did not improve at all in spite of nice attached retina. The whole retina ellipsoid was, white field, ellipsoid was lost. Other eye, we did autofluorescence, little suppression, the waves are little down, not extinguished, and some autofluorescence changes were there. We could not, any possibilities?
I think some kind of toxicity also may have happened. Maybe he's on some medication for a long period of time, which is specifically caused ellipsoid loss.
The whole
so that is
retina ellipsoid was lost. After
so if
RD
it is
surgery.
there on the other eye also, then it's a bilateral condition, then you have to think whether some
we could not get into
medical
any
cause of it, for the medicines or some kind of toxicity which has caused it.
Okay, thank you.